Good day and welcome to this news release. Today in the digital studio we have here with us Dr. Michael Wagner from the Medical University of Vienna. Good day.
Hello from Vienna.
So you just presented the clinical study results from optimization of ventilation strategies in preterm and term infants in a single center intervention study. The results were presented at the Pediatric Academic Society's annual meeting in Washington. Could you begin by telling us what the aim of this study was?
Yes, so previous studies on the benefit of the application of a respiratory function monitor in a clinical setting rendered contradictory results. And so when looking at previous data and study designs, we hypothesized that this was based on differences in the definition of patient collectives, a specific learning effect due to patient randomization rather than provider randomization, as well as a monitor design and training in monitor use. So the current study was aimed at contributing to this debate by including a broadly defined patient collective with term and preterm infants, varying gestational ages, weights and comorbidities, as well as reducing potential learning effects by choosing a non-randomized study approach.
The respiratory function monitor that you used for this study was none other than Monivent's Neo100. Could you tell us a little bit more about how the study was conducted and how the RFMs from Monivent were used?
So we had a study design, which I said before, like a non-randomized study design. So we recorded ventilations either with a hidden RFM. So the RFM Neo100 was recording data, but it was not visible to participants. So this was the control group. Or we recorded ventilations with a visible RFM. So physicians were able to see ventilations and the quality of the ventilations and were provided with real-time feedback on the ventilation quality in the second group, the intervention group. And the primary outcome that we used for that study was a percentage of ventilations with tidal volumes within a target range of 4 to 8 milliliters per kilogram body weight.
What of the results from the study? What sort of conclusions could you draw?
So we included a total of 90 preterm and term neonatal patients in this trial. And as I said, the primary outcome was the percentage of ventilations with tidal volume within a target range of 4 to 8 milliliters per kilogram. And that was significantly higher in the intervention group, so in the group where the providers were able to actively see the monitor. So we identified a statistically significant improvement when seeing a respiratory function monitor. And what we also identified is that the excessive tidal volume, which is defined as a tidal volume above 8 milliliters per kilogram body weight, which was previously associated with an increased risk of brain injury, we identified in our study that when analyzing this excessive tidal volume, this was also significantly reduced when the RFM Neo100 was visible for the providers. Also, mask leakage could be significantly decreased with the use of an RFM, as well as the percentage of ventilations with a mask leak above 50%.
And as a researcher and consultant, could you tell us anything about what this potentially could mean for the care of newborns in the future?
Yeah, so overall, our results suggest that the application of the Neo100 leads to a significantly higher quality of ventilations. And while we were able to see a trend in a higher rate of persistence of patent ductus arteriosus in preterm infants and a higher rate of pneumothorax in the control group, so the group with the hidden monitor, unfortunately, we were not able to show a statistically significant difference in patient outcomes. But interestingly, especially regarding pneumothorax, 2 out of 3 patients with the clinical diagnosis were again ventilated with excessive tidal volume above 8 milliliters per kilogram, which was not identified by providers due to the hidden monitor group allocation. So at the moment, it is hard to show significant clinical results in such small cohorts, but as we already see a trend towards a difference in clinical outcomes, we are looking further into bigger multi-center trials using the Neo100.
Were you also able to see a difference in direct clinical outcome for those babies in the study?
As I just said, this is pretty similar to the previous question, but we didn't see a direct clinical benefit, but we identified a trend towards increased comorbidities when the monitor was not visible versus less incidence of comorbidities when the monitor was visible. There was no statistical significant difference, but this was maybe due to the small cohorts. And we think that in a larger multicenter trial, we will be able to show a difference. And we definitely see the clinical benefit when the Neo100 is used.
Dr. Michael Wagner, thank you very much for being here and answering my questions.
Thank you.